There were several talks about both acquired aplastic anemia and refractory therapies and how to treat that. And then there were some wonderful talks about inherited forms of bone marrow failure and newer treatments for that, all non-transplant related. So,
yeah, but I agree. I mean, I think we had a great session, and the focus was non-transplant. I mean, transplant can be a very effective approach, but unfortunately, it's not for everybody for all kinds of reasons. So it's important to develop non-transplant approaches, as we discussed in our session yesterday. And what was interesting is that there are a lot of treatment modalities, especially in the immune.
Sure.
Immune space.
We just covered things like ruxolitinib and ramiplostim.
Antibodies,
and
different antibodies.
And they're being developed. So hopefully we'll have some newer treatments online in the near future that'll really help these patients.
Especially for those refractory patients who are not transplant candidates, those really need help. So it's very exciting to see new data, new therapies that are up and coming, and very well tolerated therapies as well. I mean, not toxic. Yeah. And a very important talks on non-transplant gene therapy.
Or two of those.
Two of those, exactly, which were very exciting to see. Now, this is more preliminary, so it's not something that can be applied like this year or maybe not next year, but I think in the coming years, we'll see more of this.
Yeah, and the last talk was a thymidine nucleoside treatment for telomerase diseases. It was very exciting too.
Yeah.
So.
These are for patients for telomere disorders like dyskeratosis congenita, and the other gene therapy was for Fanconi anemia, which is also an important marrow failure syndrome.
Treatments are similar in some ways, but very different. Obviously, for acquired aplastic anemia, we treat with either immunotherapy or a stem cell transplant. For patients with inherited disease, we look more towards, I want to say transplant, but we have to be very careful there with certain diseases because of the conditioning regimens. They can't tolerate chemo, etc. So we have to be careful with those patients and how we treat them, but they will probably not respond to immunotherapy.
Yeah, I think that's right. I mean, the objective is the same, is to restore blood formation, right? That's the goal for both. Although with the immunoplastic anemia, you have a possibility to do immunosuppression. And I think that's what's different from what you just said in terms of what those patients who have hereditary or constitutional marrow failure syndromes that is defined usually by a genetic problem or a genetic defect where the immune system is not much of a player. So giving immunosuppression is not something that would be of benefit. And then it's bone marrow transplantation with all its toxicities.
Correct.
You know, because these patients tend to be more fragile in terms of not only going through the transplant, but the complications, the months and years after the transplantation. But similar objectives.
Correct.
Getting the bone marrow to
function again.
Produce blood. Yeah. This is an important question because there are several options that are in existence but also emerging. But also, not every patient who's diagnosed with aplastic anemia has the same characteristics. So some patients would have a higher probability of doing better with one treatment modality like transplant, for example, compared to immunosuppression and vice versa. So what is happening today is that it's becoming even more important to individualize that care rather than to have like this rubber stamp. Because we're learning more about the complexities, not only about the therapies, but also of the proper diagnosis and what's really happening to that patient that's leading to the marrow failure, and what would be the best approach or therapy to try to reverse this problem.
And often it takes the patient talking with their own doctor and then saying, maybe I need a specialized center that is more up to date and has clinical trials. And the AAMDS Foundation is there to help direct them to wherever they need to go. So, yeah.
Yeah, and I think, Carlos, you brought an important point. I mean, it's getting
much more complicated.
It's getting much more complicated now, and I think I know it's hard for patients to move, and they have all kinds of local obligations to their family, to their community, and to their jobs, et cetera. But I think for these type of disorders, I think we cannot overemphasize enough the importance to really go to a specialized tertiary, usually university-based center to actually at least listen, get an opinion, not necessarily getting all the therapy there because this involves all kinds of logistics. But I would strongly recommend, and I'm sure Carlos agrees with that, to really seek this type of specialized expert in the field of marrow failure.
These gene therapy approaches, these nucleoside approaches are all novel approaches. Again, they're not here yet, but they're at least showing promise, and they're in clinical trials now. So the hope is we'll have more information later on, and we can have some new therapies.
Yeah, that's exciting, Carlos. And the reason that these gene therapies are being developed for these hereditary forms of marrow failure, because bone marrow transplantation is all we have to date, and we know that the toxicity and the medium to long-term consequences post-transplant can be very hard in these patients. So not undergoing a transplant is something that is of interest. So that's why these therapies, which are not transplant, well, in a way, bone marrow transplantation is a form of gene therapy, except that it's very brute. I mean, it's crude. I mean, you're changing the entire...
Giving all the genes.
You're changing the entire genes, your entire immune system just to fix one defect. Now, this is being much more targeted, as Carla is alluding to, that you're just fixing that one single problem, that one gene, to see if you can restore blood formation the way it should be. So this is exciting. It's still early, but I think this was we had a back-to-back talk, one on Fanconi anemia and one on diskeratosis congenita, which are the two main. There are others, but these are the two main ones that we usually deal in our daily practice. So I think this was something to keep an eye on for the next couple of years.